Hello again. Welcome to the wonderful world of craniovertebral joint mechanics. Before we can biomechanically assess and treat this region of the spine, we must ensure that the ligaments in this area are sufficient. This is particularly important for this region as the transverse ligament is essential for life. And the last thing you need is to get a really good treatment on the neck and have the patient not survive that treatment. I would just like to, in this area anyway, go back over some of the points I made on the introduction regarding stress tests and mobility testing and some of the important features that we're looking for when we do these. And I will be talking about these as we do the tests. I will not be emphasizing these later on in the video, and I'll assume that it's read by you. The first ligament we need to look at is the transverse ligament, and this ligament runs from either side of the atlas across the posterior aspect of the dens, and its function is to restrict the amount of posterior translation of the dens into the spinal canal and also to limit the amount of flexion and extension available at this joint. In order to stress test this ligament, we will shear the atlas forwards on the dens, and it's essential that we take the occiput and the atlas together anteriorly while gravity stabilizes C2. Doing this will result in a relative posterior shear of the dens into the spinal canal. Of course, what you're actually doing is bringing the transverse ligament against the dens. And as in all stress tests, we will maintain the stress until we get a solid end fill or until we reproduce signs and symptoms of insufficiency. One of these signs will be central nervous system signs, nystagmus, lateral paresthesia, bilateral paresthesia, tingling around the lips, and so forth. But other non-cardinal signs are important as well. Things like a feeling of a lump in the throat or a consistent swallow, nausea or dizziness may or may not indicate central nervous system damage. So going back to the patient, we'll do the test. Holding the C1 with the index fingers and the occiput with the rest of the fingers, we'll stabilize these two bones and control flexion and extension via the rest of your hands. We will then shear the head and C1 anteriorly while we maintain the orientation of the face to be parallel with the bed, thus avoiding flexion or extension, like so. And we will maintain this stress until we get an end fill or until we have elicited positive signs and symptoms. If we reproduce cardinal signs, then of course we will refer this back to the physician before any further treatment or examination. The next ligament we have to look at is the ligament, and this ligament is not as life-threatening obviously as the transverse ligament, but it is one that should be tested. The transverse ligament, just to refresh you again, runs from the dens, particularly the posterior aspect and the superior aspect of the dens, laterally into the area, the non-articular area on the medial aspect of the occipital condyle on either side. In the majority of subjects, this is orientated posteriorly, but in a small percentage of the population, it's an anterior orientation, and this will affect the way the test is carried out. The function of this ligament is to limit the amount of rotation and side bending contralaterally. And this is how we will produce the stress through this ligament, by contralateral side flexion. So, to stabilize the bones, we will put a thumb on the spinous process of C2 and a finger on the neural arch of C2. We will then side bend the occiput around the axis that runs through the nose. And if this ligament is intact, there will be no side flexion nor any other than a hard capsular end fill. Because of the orientation of this ligament, it's essential that we do it in flexion and extension. If we do it in flexion first, this will tighten up the majority of subjects' ligaments. And if it's negative in this test, we don't have to go ahead and test it in extension. On the other hand, if we have a positive, it could be a false positive due to the orientation, and we will then have to retest in extension. It's only when this test is positive in both flexion and extension that we can consider that we have an instability at this region. So going back to the patient, we will stabilize C2 by holding the spinous process of C2 with the thumb, and the index finger on the other side will wrap around the neural arch. The craniovertebral joints are then flexed, remembering that the axis for this flexion is through the ears, and then we will side bend the AO joint around the axis through the nose, and we shall get no movement and a hard capsular end fill. Just testing in the opposite direction so you can see where we're going. Finger is around the neural arch while the thumb is on the right-hand side of the spinous process. We will flex and side bend this time to the left, testing the right ligament. If this test is positive, then we will repeat the test in extension. The next stability test we will have to do is a vertical stability test, where we're looking for stability of traction between the occiput and the atlas and the atlas and the axis. And this stability is in part dependent on the longitudinal ligaments and of course on the dura mater surrounding the spinal cord. It's difficult to say which ligament we're testing, although the tectorial membrane is often suggested as the cause of instabilities in this region. If there is a vertical instability, then tractioning the occiput away from C2 may result in some stretching of the vertebral artery, which is running through these transverse processes. So the positive test we're looking for, or the positive signs and symptoms we're looking for with this test, is vertebral basilar ischemic symptoms and signs. To carry out the test, we will stabilize C2 by a wide pinch grip. We will then take the occiput and distract the occiput away from C2, stretching this joint. And while we're doing this, we'll be looking for signs of vertebral artery ischemia. So back to the patient. A nice wide pinch grip around C2. Spread the pressure, while the other hand, the cranial hand, cups the occiput, like so. So we're in this position. You can lower your shoulder onto the forehead to stabilize the head, and then just lean away, producing quite strong traction. The test is then repeated in extension and flexion until all three tests are negative or one of the tests is positive for vertebrobasilar ischemia. Again, if this is the case, the patient needs to be referred back to the physician. The final stability test we'll do in this area will be lateral stability at the AA joint. And to carry out this test, we'll use the soft part of the MCP area, this area here. Don't come onto the bony part, it's very uncomfortable. And this will go up against the transverse process and the neural arch of C2, and the other hand will do the same on C1. These will then be sheared across each other and then sheared in the other direction. This should be an extreme stable stress. We have the dens that will limit the movement, as well as the lateral articulations. So any instability with this test may suggest that you have an abnormality in the dens or an articular instability at the lateral joints of the AA segment. So going back again to the patient, we will stabilize C2, transverse process and neural arch, and the same on C1. Getting your arms poked out to the side, we will stress them transversely across the neck. And this test is particularly sensitive for end fill rather than the onset of symptoms.